been. And I think that we all know that the state can do a better job of pandemic response overall. So one of the principal tasks of the committee, which may or may not be accomplished through legislation, is to look at how can the state better respond to disasters like a pandemic or others. Our committee also covers natural disasters, floods, hurricanes, tsunamis, um, or even man-made disasters such as cybersecurity threats or terrorism. And how can the state better be prepared to respond to these types of emergencies, whether they last a few days, a few months, or like what we're experiencing now coming up on a year. We've held 2 informational briefings so far. The first one was when we first learned about the vaccine program, and Pfizer had just received its emergency use authorization from the FDA. And then most recently, we had with the beginning of the month on the use of the coronavirus relief funds, which was the federal stimulus money that was supposed to be spent down by the end of the year, but then the last minute got extended. So happy to answer any questions about that. Vice Chair Eli and I have been also taking a lot of meetings with departments and stakeholders to learn as much as we can. So also appreciate the opportunity to hear from you folks about areas that you think can be improved or lessons learned from your experiences in working through the pandemic. And I'll turn it over to Vice Chair Eli to add any thoughts.
Aloha. 2020 has been an experience for everyone. And I think for myself and my district, there was so much going on, from food distributions to trying to process unemployment claims and to answer any and all questions that were coming in about the Department of Health and COVID. So I think this committee is a good opportunity for the state to really take a look at how we are gonna not just combat COVID and figure this out together, but also to prepare so that in the future, if something like this happens again, we're ready for it. And so far, there's a lot of information out there, but I think right now we need to organize it a little bit so that our constituents and the greater public can understand like exactly what the state is doing, what direction we're going in, why the vaccines are so important to our communities. So I just thank the Hawaiian Civic Clubs for giving us this opportunity to share and answer any questions that you folks may have. Mahalo.
Is that going to be me, I think? So
Are we doing Q&A? Or I don't know, is it CJ and then all Q&A?
Yeah.
I don't care. I'll just go back to the video off. Bye.
I'm going to start my...
If there are any burning questions, we can answer any burning questions, but otherwise, many questions will probably be answered by CJ's presentation.
I hope so. Can you guys see my screen?
Yep.
Fantastic. So thank you all again for having me. I really, really, really appreciate the audience and the opportunity to chat. I think it sounds like this audience is probably going to be a pretty highly informed audience. So just to give a little bit of background on this presentation, my name is CJ Johnson. I am with the Department of Health Chronic Disease Prevention and Health Promotion Division, or CDPHPD, I can't even remember it. So we focus on chronic diseases like diabetes, heart disease, COPD, things like that. Around last fall, August, September, there were some changes, some fairly high-profile changes in the Department of Health in terms of leadership and some of the operational ideas. And a couple of the really big ones were that, and some of that was in response to perceived shortcomings in our outreach to Native Hawaiian, Pacific Islander, Filipino populations and these disproportionately impacted COVID populations. So I guess the first one that's really interesting, that's not represented here tonight, but I think is worth talking about anyway, is I have a colleague named Telly Matangi, who was hired in the disease outbreak division to be a lead for a Pacific Island and Pacific Islander Native Hawaiian contact tracing team that is now 20 members strong, and actually added a huge amount of in-language, culturally competent, locally grounded support for the contact tracing effort. There was some concerns and some issues with some tracing. You know, people would call and there would be concerns. Why am I getting a call from the state? People were hesitant or reluctant to talk to people that didn't sound local or speak their languages. So the department recognized the value of having this cultural competency, hired Telly and her team, and they have done an amazing job of adding that capacity and adding that competence. They're also on sort of a similar tour to what I'm on in terms of doing targeted outreach to communities that are particularly hard hit, or that they're monitoring the outbreak and checking to see where things are going on. And they're actually doing webinars. I've been coattailing. I'm actually jumping off of this webinar to go to another webinar with them when we're done. But then in addition to that, there was an acknowledgement, a recognition that our communication strategies, while we have a pretty good comms team, they do great work. They do a lot of large media, big media partnerships, TV and radio, and they were doing pretty good on that end. But there was a disconnect with some of our more vulnerable populations that were either low English proficiency or not plugged into mainstream media. And there was a question of how could we add to the work that they were doing? How could we complement it and make sure that we were connecting? It's not a surprise to anybody, I don't think, that the COVID population, these disparately impacted populations, are actually very similar, right, in composition to the chronic disease populations that we focus on, or that we talk about in the CDPHPD group, in terms of the social determinants of health and the overrepresentation of social factors, environmental factors in why people get sick. And so we were asked to help based on those relationships that we have in these populations. And I have spent since September doing outreach and education and learning as much as sharing from Native Hawaiian, Pacific Islander, Filipino community leaders, who I think the first thing that we discovered when we started doing the outreach was that in the absence of really strong DOH presence in these communities, a lot of neighborhood and religious organizations stood up and were serving the community, and were getting information and getting resources to the community. And they were doing an amazing job at it without enough resources and without maybe enough direct coordination. And so the role that we were able to fill when we started to do the work is just listening in on these conversations, joining these HUIs, being responsive, and trying to create a relationship, trying to foster a relationship with the HUIs, with the teams that were doing really good COVID response and recovery work, and trying to make sure that they had the resources that they need to do the outreach that was already having an impact, and that they had access to timely information, and that they had, as we were coming up with new information, or the CDC was sharing new information, that we were able to take that and package it in language and in a cultural context and in mediums that were resonant with the populations. So we're listening and we're hearing from religious leaders, from community leaders, from community service orgs, from academic school partners about what works and what doesn't, what sounds authentic, what's credible, what's convincing, and what isn't, and making sure that we are engaged in that way. About a month and a half ago, I started doing sort of a focus group talk story tour of religious leaders and community leaders, and just asking about vaccine. Right, that was the big issue that we've been thinking about for the last couple of months. So that has evolved and formalized a little bit. At first, it was just go in and say, here's a couple of things we know, it's coming. Here's what we know about the safety. And then over time, I was gathering a set of frequently asked questions, things that people were, night after night, everyone was asking similar questions. And so that developed into a presentation. So I start these things off with a presentation, and then usually we go to question and answer. And that's the part that's really interesting to me once we get through the kind of the basics and into the conversation. But I think up front, the really important thing to share, and I think all of you know that, is this is as quick as the COVID situation and the virus information evolved, the vaccination information is evolving much more quickly. And I have given this presentation probably 4 or 5 times a week for the last couple of months. And in fact, this will be my second of 3 today, and it will be different from the one I gave 2 hours ago. The information is changing. What's known, what's public, is moving very quickly. There are going to be, I'm going to share a lot of background on how the vaccine works, on how we decide on priorities. There'll be some information once we get into more detail towards the end that I'll defer, and I'll say, you know, we don't have public information on that yet. And it's not, I want to be really clear, we're not withholding anything. It's just, we don't want to give out bad information or create false expectations. So please bear with me if there are some things that we don't know how we're going to approach them yet, but we have more new information every day. So obviously I'm here tonight to talk vaccines. That's the big topic, right? They are the key, a really important key to stopping the pandemic, saving lives, getting back to normal. But what I start with a really basic question of what is a vaccine, because I think it's not even broadly understood that a vaccine is a kind of medicine that helps your body protect itself, and it's not a cure, right? It doesn't cure a disease, it's a protective measure. So the way I've been talking about it with the public is that it's like kind of a shield to prevent illness. It won't help a person who has a disease recover or reduce symptoms, but it will greatly reduce the chances that a person will get sick if they're exposed to the disease. Right now, there are 2 COVID vaccines that are approved for use. They're made by Pfizer, BioNTech, and Moderna. At this time, those are the only approved vaccines that will protect against COVID-19. Others are being studied and might be available in the future. And this is a really important key point, because there's a lot of information in this presentation that's timeline based. And when we anticipate getting to certain volumes of people vaccinated, throughput, all of this could change really dramatically depending on additional vaccines becoming available. So everything we say could change really quickly if something comes through. And that's what makes this kind of challenging, right? Is we want to give information, but things could speed up. Most of the vaccines that are available or being studied right now require 2 shots to be effective. The Pfizer vaccine requires 3 weeks between shots. The Moderna vaccine requires 4 weeks between shots. When you get your first shot, you'll get a card that will tell you when to come back for your second shot. Now, you may have heard people talking about mRNA. Both of the vaccines use a new type of vaccination called mRNA. That's messenger RNA. Conventional vaccines use a dead or inactive germ to train your body to fight the live germ, to fight the real disease. But mRNA vaccines, or messenger vaccines, share instructions to teach our bodies how to fight the germs without injecting the actual live germ. So I like to describe it as like a wanted poster or a Polaroid. It introduces a likeness of the germ and says, hey, be on the lookout for this guy. And your body from that learns how to fight the disease. The really important key point there is because it does not include, someone's mic is open? Because it does not include a live virus, you cannot get COVID-19 from the mRNA vaccine. That's a really important point. Sometimes when you hear mRNA, RNA, DNA, does that mean that it affects my DNA? No. mRNA never enters the center of the cell, which is where DNA is kept. So our bodies read the mRNA, they throw it away, they get rid of it as soon as they're finished reading it. It does not affect our DNA. It does not interact with our DNA in any way. It doesn't even go to the same part of the cell. The 2 available vaccines are around 95% effective. And what we mean when we say a vaccine is 95% effective is that for every 100 people who receive the vaccine, about 95 of them will become immune to COVID symptoms soon after they complete their course. We think it's around a week at this point after the second dose. The other 5 might still become infected, but they're unlikely to require hospitalization, more likely to have a less severe course. So that's pretty cool. Some people who are vaccinated do experience side effects. Common side effects include sore arm, fever, body aches, headaches, fatigue, and according to Dre, I guess the munchies is another side effect that we can expect. For most people, the side effects are mild enough that they do not interfere with normal daily activities. There are more severe reactions, but they are uncommon. Side effects tend to go away within 1 to 3 days. So there are 2 different ways that people can become immune to COVID-19. One is the vaccine, and the other is recovering from the disease itself, which is called natural immunity. Because COVID is a new disease, we don't know how long natural immunity lasts, and evidence suggests that it might not last very long. We won't know how long vaccine immunity lasts until the vaccines have been in use for longer. So both natural immunity and vaccine immunity are being studied really closely by medical experts, because that again is another one of these question marks in the timeline planning that we honestly, we don't know yet. People have asked the question, does it mean that we're going to have to annually get a COVID booster? The answer is we have no idea. It's entirely a possibility depending on how long these things last. They're being studied and we'll know more over time. COVID-19 vaccination is recommended for all adults except those with allergies to vaccines, severe allergies, and some immune compromised individuals. If you have a history of allergies or a weakened immune system, please ask your healthcare provider if the vaccine is recommended for you. We want to be really clear, we're giving public health advice and not medical advice here today. So when the vaccines, I think that this is kind of an interesting bit of background that I think is really important to think about when we're talking about the distribution process. Even before the vaccines were approved by the government for use, the vaccine manufacturers thought, oh, this vaccine is really promising. Our clinical trials look really good. We've had a lot of experience working with the government before, so it's our sense that the government is going to approve this. So what we're going to do in the meantime is make a limited batch of it so that when they do approve it, we have some ready to go, and we don't have to start from scratch. So even before, well before the government approved the vaccine, both of these manufacturers started making them. And so on the day, you probably remember, right? On the day that these vaccines were each approved, there were planes in the air carrying the vaccine all over the country because they already had an amount. But that amount was limited at first. Now they're making more and more. They're scaling up. They're ramping up capacity. With the new administration in the White House, it looks like we're going to actually even ramp up capacity even more. So the key point is that there's a lot of vaccine being made, but there's even more planning. There's the volume of vaccine production is increasing dramatically. Now, on the local side, vaccine distribution is also speeding up, and there's a lot of things, there is staff training, volunteer training, processes that we're learning and teaching new people. In the first month alone, we administered about 50,000 doses of vaccine. That's really impressive. We're very optimistic that we're going to increase that dramatically. The first pods went online this week. There's even more happening next week. There's a ton of capacity being developed that we're really, really excited about. There are complicating factors. I think that we have to really keep in mind is that our supply chain is really fragile, right? We're a large population, very remote island. We have a very fragile supply chain. And if it was disrupted, what would we do to make sure that we had vaccine available for second doses for people that had already gotten their first doses? So there's a need to have some in reserve. There's a need to have some background. And just the challenge of vaccinating large amounts of people without creating large gatherings. We've learned from the experience of other jurisdictions and other states. If you just put out notice, hey, come here and get vaccinated, people will camp out overnight and people will show up way early for their appointments. So the challenge of how do we get people in and out really quickly and a lot of people, but not in a way that is putting people in danger by creating mass spreader events or large events. So we are continuing to increase that capacity as supplies increase. We have very little control over the supplies. There are weeks that we generally don't find out until Thursday how much vaccine we're going to get for the following week. And there have been times when it hasn't been quite what we were expecting. So that's always a challenge. That's something we have to be prepared for and resilient against. But I think all these things are smoothing and are coming online better. So going back a little bit to the science stuff, the vaccine has not been studied in pregnant or breastfeeding women and their infants, but in general, mRNA vaccines are not thought to pose a risk to those groups. COVID-19, on the other hand, can make pregnant women and their fetuses very sick. So our recommendation is if you are pregnant or breastfeeding, talk to your healthcare provider about whether or not you should get the vaccine. It's a personal decision. So far, no vaccine has been studied in children under 16, younger than 16. At this time, one recommended vaccine in use is for people 16 and older. The other is for people 18 and older. Information will be made public as we learn more in the coming year, if that changes, when that changes. But for now, we are not planning, the DOH and the state are not planning to vaccinate imminently anybody under 16. So this is the big one, right? Who decides who gets vaccinated first? So the framework rules for who gets vaccinated in what order were created by the Centers for Disease Control, or the CDC. And then from there, the Hawaii Department of Health, along with a large group of expert partners, set about creating a local list that was specific to our needs in the state that was based on the CDC guidelines. So I talk about this in two parts. One of them is the general risk categories that sort of that are matrixed together and define the risk groups, the 4 sets of risks. And then the other is our actual tier system or phase system. You probably heard a lot of talk about phases lately, and I'll get into that in a minute. But I wanted to start with the risk groups because I think the risk groups are really important to understanding the phases. So the 4 risk groups that were identified by the CDC as groups that are at higher than average or very much higher than average risk from the disease are kind of defined as follows. So the first one is risk of of contracting COVID. And that's just as some examples, people who work in direct patient care in hospitals and nursing homes, and people who handle biological waste in hospitals and nursing homes, like doctors, nurses, cleaning staff, right? So that is a population group that you would expect to have a higher risk of contracting COVID than the general population. The second is risk of serious outcome or death if infected. That's ones we know a lot about these already, right? So our primary one, our largest group is as older adults, Kapuna. They are at much higher, much more significant risk of serious outcome or death if they contract COVID. There's also folks with underlying health conditions like diabetes, hypertension, COPD, people who are immune compromised. There's a longer list, but that's the larger populations of people who have underlying health conditions. So that's our second risk category of people that are at a normal above baseline risk. The third is the risk of negative societal impact. And this is kind of an interesting category, but it's essentially folks who, if it's workforce people who, if they were sick, would, or incapacitated or were dead, would have a really significant impact on the functioning of society, right? So there's some folks that you wouldn't have even thought about, but like our harbor workers are really important to keeping the ships coming in and out. Government officials and key staff, transit workers, postal workers, utilities workers, air traffic controllers, folks that, again, there's small groups of people that if they were to become ill, it would have a really serious ripple effect on society as large. So that's risk factor number 3. And then number 4 is risk of spreading COVID to others. So that's your folks that are in congregated, it's the biggest example that we use is folks that are in congregate housing, like correctional facilities, large households, dormitories, and shelters. So you take those 4 risk factors and you plug them into a basically a math problem, right? And you figure out, well, based on those risk factors, what population segments demographically and occupationally are the highest priority, and then you create those prioritization lists. And you've probably seen these by now. We've broken them up into phases. So right now we are talking about phases A, B, and C, phases 1A, B, and C. Phase 1A started in December. We're ramping up high speed and phase 1A right now. Healthcare workers, long-term care facility residents, right? So people that are paid or unpaid personnel that serve in healthcare settings and have potential for direct or indirect exposure to patients and infectious materials. There's 40,000 people that fall under that category. We are vaccinating them. I was over at Queens right now. I saw how many people are going through. And then long-term care facility residents, so adults who reside in facilities that provide services, including medical and personal care to folks that are unable to live independently. Again, another 10,000 people. At different parts of the state where we've started to ramp up phase 1B, I would say that the state focus operationally is still very much on making sure that we're getting that 1A finished, and we also are ramping up 1B. 1B started a little bit in December, and now we're rolling it up more. It's going to go through March. That is Hawaii residents age 75 plus. There's a total of 109,000 approximately 75 plus Kupuna residents in the state. That's a huge population, right? It's a lot of folks. And then frontline essential workers. And this is a subset of essential workers whose duties must be performed on site and require being in close proximity to the public and coworkers, and are at a substantially higher risk of exposure and are essential to the functioning of society, with special attention to life and safety first. Another 50,000 of those folks. So then our phase 1B is our frontline essential workers. First responder, I'm sorry, so this is the more detailed explanation. Now this is one of those places where the information is changing very quickly. My understanding is this is actually today being tweaked a little bit, but I'll still share the rough outlines of it. The phase 1B is first responders, corrections officers and staff, emergency services dispatchers, individuals essential to federal, state, and government operations, critical infrastructure, critical utilities, teachers, childcare, early educational support staff, U.S. Postal Service employees. Again, like I said, I know I think that's being tweaked a little bit as we speak. So the next time I give this, if you want to come check it out, there might be a little bit of different information. And then phase 1C starting tentatively at this point. Again, some of these timelines may change due to availability and new vaccines becoming available, but we anticipate a March start for 1C, which is Hawaii residents over 65, individuals of all authorized vaccine eligible ages with comorbid and underlying conditions that put them at increased risk, and essential workers not included in 1B. So that's that larger pot of essential workers. And that's a huge group of people, right? That's 400,000 people. But we'll get through the first, and then we'll start working on that in March. Some additional considerations for how to think of those first 3, that phase A, B, and C. There's vaccine distribution could occur concurrently between phases and differently geographically. So for logistical reasons, it's entirely possible that one island or one neighborhood or one facility might be a little bit further ahead or behind in their phases implementations. And that's not a cause for concern. I think we really want to make sure that folks understand. I think early on there was a little bit of like, hey, how come they're cheating, or how come they're getting ahead in line? There's no cheating, there's no ahead in line. We do our best at estimating the populations of these different groups and the willingness or the enthusiasm for the vaccine within a facility or population, and that we may be off and have to recalibrate, but in the meantime, we would rather get shots in arms than have them just sit there on the shelf unused. So there's times when you'll see that maybe Maui gets a little bit ahead, or somebody else gets a little bit ahead, or a hospital here gets a little bit ahead. We're just the number one priority is shots in arms. And again, some populations, some areas larger, smaller than others, but we're always recalibrating that, trying to keep it moving along steadily and allocate the supply appropriately. Another thing is that vaccination might be prioritized geographically in consideration of current disease activity, disproportionately affected communities, and health and socioeconomic vulnerabilities. So that's a place where the question comes up a lot, because Pacific Islanders have this very disparate impact, right? They account for about 4% of the population, but something like 26, 27, 28, depending on the week, percentage of our cases. So would we target people based on that demography? The answer is we're not currently doing that, but there's no we could. If it became necessary or was deemed a priority, you could shift that a little bit to focus on communities that had higher populations, higher percentages of certain populations, if that was a risk factor. So we want to be flexible and sort of resilient in that way. Phase 2 and 3 is the general population, and that's projected to begin in early summer 2021. But again, all this could change depending on supply, availability, additional vaccines coming online. These timelines could change a lot, but that's our best case at this point. How much will the vaccine cost? The vaccine will be free to the public. In some cases, vaccine providers may charge an administrative fee for the vaccine, but most providers in Hawaii have agreed not to do so. So the vaccine is free. The vaccine itself is free to the public. Department of Health is working really closely with our hospital partners, our healthcare partners, our TV, radio, newspaper, community partners to spread the word on availability and schedule. There is no magic bullet. There's no one, magic place. We really want to get out there on all channels and broadcast on all frequencies to make sure that everyone knows when they're available, when they're eligible for vaccination. If you're in phase 1A, or if you're in one of those occupational risk groups or phases, the likelihood is that you will hear from your employer when it is time for you to be vaccinated. So if you're a harbor worker, that's how those are being, the occupational risk factors are being distributed and communicated through the employers. Otherwise, we do have some information on eligibility. So we have the 75 plus and some of the other essential worker eligibility. If you go to our website at hawaiicovid19.com, we have several portals where you can click through and go to the facility, the vaccination facility that's most convenient for you. And I'll share that again at the end of the presentation. So there's actually, and this is another bit of information that I'll be updating in the future, but one of the main points, there's actually 4 different ways that we're distributing, but one of the big ones is the closed points of distribution, or pods. You'll probably be hearing a lot about pods over the next several months. Pods are setups for open, centrally located public facilities that are set up to vaccinate large numbers of people very quickly. So you've probably heard about the Pier 2 pod that started this week. So the idea is to create places that are really convenient for folks to get to, where there's a lot of capacity, that have the facilities necessary to get people in and out, that have parking, that people know where they are, they're comfortable, familiar. So another important point here, and this is another lesson learned, I mentioned this earlier, is all of our pods are operating, all the pods planned are operating on appointment basis. The last thing we want to do is have lots of groups show up at dawn and wait for their appointment and create a super spreader event. So we don't want folks, these won't be advertised as, show up at Pier 2 at 6:30 a.m. and wait for your turn. So everything will be done by reservation. After you have had both of your shots, you will still need to wear a mask, avoid crowds, and close contact with other people outside your household. Medical experts need to learn more about COVID vaccines before changing recommendations to prevent COVID spread. DOH and state and local leaders will let the public know when it's safe to stop using those preventative measures. There's another new thing that I just added today that I'll add to the presentation, but we've been getting asked a lot about the Safe Travel Program, and does being vaccinated mean that you don't have to skip the Safe Travel Program? The answer to that is you do have to continue to use the Safe Travel Program. There won't be an exemption for people that are vaccinated, and that's for the same reason. We don't know enough about how the disease spreads spreads or whether the vaccine stops you from becoming a spreader. We're watching. We will, and when we do know, we'll share that information, obviously. But right now, the recommendation does not change whether or not you've been vaccinated in terms of any of these recommendations or the Safe Travel Program. The ultimate goal here, you probably have heard, is herd immunity. And herd immunity is when the community as a whole, as a population, is effectively immune to an infectious disease. And that's either through previous infection or through vaccination. And that provides indirect protection to people, even if they aren't vaccinated and aren't immune, because it makes it harder for the disease to spread. So this is a little visualization I made of, let's say the red folks in here are our contagious people within the population, and the blue folks are the people that have been vaccinated. You can see that even though the entire population is not vaccinated, there's enough people in the population who have been vaccinated that they're not able to spread, right? They're insulated from spreading the disease to folks that aren't. So that state is what we refer to, what we're talking about when we refer to herd immunity. Excuse me, herd immunity. The challenge, of course, is this is another one of those question marks. We don't know yet what that magic number is, and that's another situation where we're watching really closely. We have the luxury of being behind in some of the other. We have lower outbreak numbers in some other places. We're behind in our outbreak, so we'll be watching other population centers and learning from other folks. And I think hopefully we'll know, sooner than later what that sweet spot is where we need that number of people that we have to have vaccinated. It is really, really important to get your annual flu influenza vaccine or flu shot during the COVID-19 pandemic. It provides a lot of benefits. It keeps you from getting sick from the flu. It reduces the severity of your illness if you do get the flu. It reduces the risk of hospitalization if you get the flu. Flu shots are very important to keep you healthy and to keep our clinics and hospitals from being overcrowded during the pandemic, but they will not protect you from COVID-19. So we still are recommending that everyone please, please, please get your flu shot and get vaccinated against COVID-19. The recommendation from CDC right now is 2 weeks apart. So if you just got your flu shot last week, and you're eligible, you're going to need to wait for a couple of weeks between that flu shot and that COVID vaccine. But we do recommend that everybody get both. So I just put notes in here because I got new information just today that I didn't get to put in the slideshow. So I mentioned the distribution. The main distribution channel is pods. Others are large long-term care facilities, which we have deals worked out with the large pharmacies. The pharmacy chains will be handling the large long-term care facilities, and then our small local chains will be working with these smaller long-term care facilities. And then the federally qualified health centers are also going to be there will be points of distribution. So those logistics are being worked out right now. I'm really excited about that. That's going to ensure access for the populations that use federally qualified health centers for their healthcare. I mentioned the Safe Travel Program already. And then I also mentioned that there was some discrepancy on these answers. The current recommendation is not to, will we be vaccinating caregivers who accompany Kapuna, the 75 plus, to their appointments? The answer is no. And that's because the priority is the Kapuna. We have a limited supply of vaccine. We really, 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 really want to get as many shots in arms with Kapuna as we can. So at this point, the recommendation is not to vaccinate caregivers. And then the sooner we get all the Kapuna vaccinated, the sooner we will be able to vaccinate more of the general public. So that's the state of that right now. I want to share in closing that we have a really, really robust library of multilingual resources. We've had a lot of work products from this outreach effort that we've been doing, the COVID outreach and public health education, or COFI campaign, that I'm part of. Almost all of our documentation, all of our COVID guidance is available in multiple languages at this point, and all of our priority PI, Olelo, and Filipino languages, in addition to the standard ones. We're really excited about that. That's a change from when we first started. The new challenge, of course, is that our translation turnaround is not as fast as we'd like it to be. So we've been doing some really creative translation processes with some of our local and internal talent, some of our staff who are bilingual, and we have gotten our turnaround on translation and on our FAQ a lot faster than it would be if we were relying on professional services. We have an FAQ up right now. All of this information that I just shared is available in all of our priority languages, and the next step is going to be some video PSAs that we're making, but I'm gonna actually share that screen real quick. But we're really excited about this work because we think that it's what we heard a lot from our community partners would be really valuable, is multilingual resources. Let me actually change the screen sharing real quick. Uh-oh, Trey, could you re-enable? I lost the ability to share screen. Oh. Is Trey on? That's all right. Oh, there we go. Thank you, Dre. So if you go to hawaiicovid19.com and click on the resources tab up at the top, there's a tab for multilingual resources, and that will take you to this page. And you can see that we have our resources sorted by some of our languages. We don't have all of the sorting yet done, but we do have our priority Pacific Islander languages, Samoan, Marshallese, and Chuukese. We're adding more frequently. And then our frequently asked questions are available here. And what we're really excited about this is if you click on one of these, it's a very simple Word document. It's not a fancy, completed document. We just wanted to get the information out there in the language out there, translated and accessible. And we have all of these for all of our languages. The nice thing about this is that you can share this link. So if any of you has a website, or you have partners, community partners, or churches that want to have the latest information for their language populations, they can share this and it'll update. And because it's a Google Doc that we're updating on the back end, it will automatically update as we add new information or as information changes. So if a church wants to host information, they put this up, they don't have to worry about it being current. It'll always be current. They can either put it as a link, so you can just copy the link and put it in there, or we've done a little bit of a fancy deal where you can actually embed it, and I put the embed code in the bottom of it. I want to show you what the embed code looks like real quick. Oh, hold on a second. And the embed code looks like this if you actually embed it into a website. And then again, it automatically, this is my personal test site, but I just wanted to show what it looks like. So that's all there. So if you want to make, if our community partners want to make PSAs or create their own flyers, we also will be creating flyers, but we just didn't want folks to wait until we create our own flyers. So all this information is available in all of our priority languages. And we're adding to it frequently based on these conversations and this outreach work that we're doing. We just want to make sure that everybody has the information that they need in a language and in a medium and in a context that's accessible and can help people make informed decisions about the vaccine. And then as more and more of the population is eligible for the vaccine, that they know when and where to go to get information and to get vaccinated. So I'm going to stop sharing. And that's my piece. That's my 2 cents. So I really appreciate everybody's time. I get just as much out of the conversation. If people have questions or thoughts or advice on how we can continue to do a better job of outreach and making sure folks have good information and know where to go for when it's their turn to sign up. So again, Dre, thanks for inviting me, and I'm available for questions, and I'm glad to be here. And I'll put some links in the chat for if people want to get want to have some of this info, or I'll put my email too if people want to reach out directly. So thank you. Oh my gosh, any questions? Or did you guys, our representatives, want to add anything or jump on top of that, or any thoughts? Or Tuesday night was a lot more vibrant than you guys are. Well, I'll put the info in the chat.
Hi, I have a question.
Hey.
We may have missed it. Hi, I'm Chris, and this is Kama. So for rural community residents, right now all of the vaccination centers are centrally located. I'm just talking about Oahu.
Mm-hmm.
Are there plans? Did you talk about that? If are they gonna be able to go to the community health centers at some point, or that's kind of what's in the works, but not yet?
Yeah, I think we'll hear about it relatively soon, that the federally qualified health centers are going to have their own vaccine quantities to distribute to their populations. And they'll also be responsible for like language outreach and connecting with I talked to somebody in Waimanalo today who said that their plan is like they'll have staff calling, like calling their older clients and telling them that they can come in and stuff.
Okay, and you can only register when your current phase is open. There's no pre-registration for upcoming phases.
Yeah, because we just don't know, right? It's not entirely clear yet when, and I should say all this is my best understanding. If the committee knows differently, please jump in. All of this is very fluid, but I'm presenting what I believe is the most accurate information. But there's a lot of information out there, so please share if you know otherwise.
Thank you very much.
Yeah, you bet. Put my email in the chat. And I'm happy to do this if anybody has other groups that they're involved with. This group, I know a lot of you guys are legislators, are involved at a pretty high level, so this is probably a lot of elementary stuff. But if you have other groups that are interested and don't have information or have questions, I'm happy to address them too. So I'll put my info in here. And been doing I've been doing a lot of Kapuna outreach too, which was not part of the scope, but is something that ARP had me, and they really liked the presentation. So now everybody's calling me for that too. So happy to talk to anybody.
Sorry, Dre, I can't hear you.
So I just put my email address. Feel free to email me directly, and then I put a link to our multilingual resources page. And we're adding stuff. There's also a sign up. There's also a sign up link at the bottom of that page on all of our HawaiiCovid19.com pages, where you can go and enter your email address, and we'll send weekly updates to new documentation. And we're putting information out really aggressively in terms of our social media, our partners, our conventional media partners, our website. So we're really putting a lot of effort into getting. We have 16 languages. I think that's pretty unique. I don't know a lot of other states are doing support for 16, like significant population of 16 different languages. So it is challenging, but we're getting better at it, and we're excited to be able to support them with good information.
Rep Ichiyama or Rep Eli, do you have any comments you want to add, or any closing remarks, or just any thoughts that may have come to mind during TJ's presentation?
I would just add that I recently talked to CVS, and they are looking at starting to be a vaccine distributor. They're still in very preliminary stages, and they get their supply directly from the feds. So they're working very closely with DOH. But I know a lot of folks, speaking to the question about rural access, feel comfortable walking into their local Long's pharmacy to get their flu shot. And so it would be something similar to that. And they're hoping to make an announcement sometime next month.
Great. Rep Eli, anything?
No, thank you. That was a really thorough presentation. You covered everything, and the links are good too. So I think just at this point, if anybody has questions for us, because like I said, I think your presentation was pretty thorough.
Or if for Representatives Ichiyama or Eli, if you have just any other insights going into session, given where we are with pandemic, given where we are with the state's economy, if there's just anything that you want to share. I know you guys have gotten through a couple of weeks now, at least 2.5 weeks of budget briefing. If there's anything that you think, might be helpful for community advocates to know as we go into session, we'll welcome your comments and input and insights now too, if you are open to sharing.
I think probably just, that everything is going to be virtual. And so our committee hearings, everyone is still going to be able to to give testimony. It's going to be done remotely though, which I think is a great thing and is a great opportunity too for a lot of our neighbor island communities to add to the discussions that we're having. So I think just taking a look at our legislative website and getting information on how to submit testimony, because you can still give a testimony to the hearing, live, but you will also be need to submit written testimony to be part of the record. Just stuff like that, like where things are changing, and we're getting readjusted to this new normal session, which is not normal. So I think it's just going to be a very different session than what we're used to, I guess. But just taking advantage of the opportunities, to give testimony and to add to the conversation, and contact us, our offices, like if there's any questions or concerns going on in the greater public, so we can address them quickly with the departments. I think is the main thing I want to put out there.
And Rep Ichiyama, do you have anything you want to add about what we can expect for the 2021 session?
I would echo Vice Chair's statements. It's going to be a learning curve for all of us to go virtual, but I think it's good, and it's forced us to make that technological jump, which I don't think, if we didn't have to go through the pandemic, I don't think it would have pushed us to make this kind of change. So maybe there's some silver lining there. I would just also add for any advocates that we are looking at a shortened session. So we're ending in April. Members also have had their bill introduction limits reduced. And so I think leadership from both the House and Senate are trying to send a signal to expect fewer bills to pass this year. And I think on top of that, because of the budget shortfall that we're facing for next fiscal year and the year after that, we really want to level set everybody's expectations at the beginning that there's going to be no general funds available. Very, very, if any, appropriation bills may pass. And in fact, one chair told me that he's telling anybody who wants to introduce an appropriation bill that they need to put in their purpose section what other general fund program they're going to cut in order to pay for this addition. So, putting it right up out there that there's really no flexibility in the budget.
And just to clarify, there's no GIA this year, correct? There's no grants and aid.
Yeah, there's none. And so that's why it's going to be a different year. It's going to be tough, but I think, with the vaccines coming out and with the committee that we have, I think there's opportunity for us to move forward from this. It's just going to take some time. I think we're all adjusting, the greater public is adjusting just as we are. We are a reflection of our communities and our districts. So we're just moving forward the best way that we can.
So I did just put in the chat links to the legislative calendar. It is shortened, right? Adjournment is scheduled for the last week of April. And I did also put in a link to the new testimony procedure. So all of this is on a Capitol homepage, but those are good reminders, right? For those of us who are just regular, right? We can set our lives based on when, final decking is. I mean, everything's a little different this year. And, even to how we, need to submit testimony and stuff. So yeah, it'll be a fun session, but very different. And, I think we'll all need to adapt to the new way of doing things. All right, I think we're about to wrap up, but any last comments or questions from anyone, any of our members? Any questions? No, nothing. Going once, going twice.
Nothing here.
I
Yes,
really
thank you
appreciate
very
everybody's
much.
time. Yeah, thank you so much.
Thank you.
Take care.
All right, well, with
Thank
that, we will adjourn. So thank you everyone for joining us. Thank you to our guest speakers. Next month, our meeting is on February 18th, and we will be hearing from the Department of Hawaiian Homeland. They have a fun casino plan in the works that I think we, very much like to hear from them and what their plans are, as well as, this year marks the 100th year of the anniversary, or, it's been 100 years that the Hawaiian Homes Commission Act has been enacted and in place. And so, we should hear from the department about, what's going on in, this year as well as for the next century. So, Rep. Ichiyama, I saw a hand. Go ahead.
Sorry, Dre. I just want to make a quick announcement, a plug for the Aloha Safe Alert app. If you haven't downloaded it yet on your smartphone, I highly encourage you to do so. It's called Aloha Safe Alert. It is the State of Hawaii official exposure notification app. It was made by AIO Media in partnership with the Department of Health. But the way it works is really interesting. It uses a special type of Bluetooth technology. So you download the app on your phone, and then if other people have the app on their phone, they can measure the distance between the two phones using low energy Bluetooth. And if you are within 6 feet of another phone for more than 15 minutes, that phone is considered a close contact, and they exchange anonymous codes. So let's say if somebody tests positive for COVID-19, if they have the app on their phone, Department of Health will send them a link. They upload that link into the app, and then the app will send an anonymous notification to anybody who is within 6 feet for more than 15 minutes of that phone. And it's a really great tool because it will rapidly increase the first notice that you get if you've been exposed to somebody who's tested positive for COVID-19, so that you can know right away that you need to get a test and that you need to quarantine. It's also completely anonymous. So like, in our Starbucks apps, we have to create an account and enter in our emails. For this, you do not even have to do that. They do not track your location. You don't even put in your name. It's just a straight download. You keep your Bluetooth on, and it will consistently check to see if you have any exposure notifications. So please encourage your family and friends to download the app and make sure to keep their Bluetooth on.
We're working on language
Thank you
access
for that
too.
reminder. Oh, great. Okay, last chance for any questions before we sign off.
Thanks
If
for letting
not,
me
everyone
present
have a
in.
great evening. Of course.
Thanks so
Wait, Melissa,
much.
do you have a question? Or are you waving goodbye? Okay. All right, everyone. See you at our February meeting on the 18th.
Take care.
Thank you.
Take care.
Bye.
All right.